Hello, hi, am I audible?
Hi, Dr. Jyoti. Yes, you are.
Yeah. Hi, Dr. J. Okay. So we'll start in 5 minutes.
Yeah, yeah. On time, 6:30.
Okay, good. Please.
Yes. Mm.
Sir, can I start at 6:30?
So, yeah, we'll just have to confirm. I think there are three more members who are supposed to join, right? We'll just wait for 5 minutes, and if they don't, we'll just start. Shouldn't be a problem.
Okay, sir. We'll start at 6:30.
Mm.
On behalf of the International Association for Integrated Oncology, a very warm evening to all our esteemed faculty members, delegates, and participants joining us today. Expert Insights Hemato-Oncology. Tonight, our focus centers on a highly crucial and complex topic, difficult to manage myeloma. To set the stage for this evening academic feast, it is my absolute privilege to introduce our program director, Dr. Jay Juvikar. Dr. Juvikar is a consultant clinical hematologist and hemato-oncology specialist at Seth GS Medical College and KEM Hospital, Mumbai. I now invite Dr. Jay Juvikar to deliver the opening remarks and set the context for tonight's webinar. Sir, the virtual podium is yours.
Yes. Thank you, Sapna. So, thank you, everyone. Thank you, all faculties, to spare your time this Tuesday evening. And thank you, IAIO, for letting us do this meeting. So myeloma has evolved from triplets, quadruplets to bispecifics, and now further CAR T, trispecifics, as well as in vivo CAR T. But still, there are problems, there are issues which we have, and those cases are really difficult to treat. So this program has been made for that, especially difficult to treat myelomas, and it will consist of two lecture series and one panel discussion. So without further ado, let's start our first lecture series. So our first seminar would be by Dr. Jyoti Chirmade, and her topic would be CNS involvement in multiple myeloma. Over to you, Dr. Jyoti.
Yes. Hi, good evening, everyone. Hello, am I audible?
Yes, ma'am.
Yes,
Good
Dr. Jyoti,
evening.
audible.
Yeah. So, we'll start with the presentation.
Yes, please.
Yeah. Just give me a minute. I'll just share my presentation. 2 minutes. Is the screen visible?
Yes, Dr. Jyoti, your
Yes,
screen is
ma'am.
visible.
Yeah. So we'll start with the important topic in multiple myeloma, CNS involvement in myeloma. So these are the learning objectives of today's lecture. So coming to the definition, CNS involvement in multiple myeloma is defined as plasma cell infiltration of the CNS, meninges or CSF, which has to be kept in mind that it is distinct from osteodural disease causing compression. It is rare and a devastating extramedullary complication with poor prognosis and has significant hurdles in both early detection and effective treatment. Known as paradox of success, which means that modern systemic therapies such as T cell redirectors, quadruplet combinations, they extend marrow survival, wherein the CNS emerges as a critical sanctuary site. Despite significant advancements in multiple myeloma treatment in the recent years, the overall survival of patients with CNS involvement in myeloma remains markedly poor. So overall incidence is around 1% in myeloma patients and 20% of the extramedullary relapses. It occurs in around it occurs in about 2 to 3 years after initial myeloma diagnosis and can occur sometimes at presentation. Median age is younger than typical myeloma patients. The reported prevalence likely an underestimate due to the diagnostic challenges and low clinical suspicion for CNS myeloma among providers. The rising prevalence is likely due to a longer overall survival, allowing the dormant CNS clones to proliferate. So, what are the risk factors in CNS involvement of multiple myeloma? Extramedullary disease possesses a 10x risk of CNS involvement. The high-risk cytogenetic features such as deletion 17p, translocation 414, translocation 1416, 1q amplification are also risk factors for CNS involvement. Plasma cell leukemia, multiple prior therapies, and high LDH. IgA and IgD paraprotein, lambda chain restriction on SPP will possess a high risk factor for CNS involvement. Mutations such as MAFB22, TP53, RAS mutations, and MYC overexpressions. So this is a diagram, a chart showing frequency of high-risk features in CNS myeloma, of which cytogenetics in high-risk cytogenetics, high frequency of CNS involvement is seen. So a multi-institutional retrospective study of 172 patients was carried out, and a risk factor based on the risk factors, a scoring system was developed. So 0 to 1 adverse fish abnormalities and no previous lines of therapy. They fall into a low risk group with overall median overall survival of around 25 months. With more than one adverse fish abnormality or one this group falls into intermediate risk group and has a median overall survival of around 5.5 months. And more than one adverse fish abnormality and more than one previous line of therapy has it falls into a high risk group with median overall survival of around 2 months. So coming to the prognosis of this disease, median time from multiple myeloma diagnosis to CNS involvement is around 15 to 28 months. And post CNS myeloma diagnosis, the OS, overall survival, is historically between 3 to 7 months, which is very less. So, how does CNS involvement of multiple myeloma take place? It can present as a leptomeningeal disease, which is most common. It can present as a intraparenchymal lesion or cranial nerve involvement or spinal or cauda equina disease, or a permutation and combination of all the above presentations. So coming to the pathogenesis of CNS involvement, there are three basic mechanisms which have been involved in the pathogenesis. One is clonal selection, a selection of aggressive subclone which has distinct biological abnormalities which drive survival outside the native bone marrow microenvironment, and loss of stromal attachments and increased motility. Loss of stromal attachments because of decreased VLA4 and CD44. Loss of CD56, which is a neural cell adhesion molecule linked to CNS homing, and decreased tetraspanins such as CD81 and 82 influence the multiple myeloma cell migration and invasion into CNS with structural compromise of blood-brain barrier and enzymatic invasion by the myeloma cells, which are very rich in enzymes such as MMP2, type 4 collagenase, and heparinase. So this leads to the CNS homeostasis of the selected aggressive subclone. So how do these patients present? Headaches are most common complaints, visual abnormalities, mental status changes, paraplegia, paraparesis, cranial nerve palsy, and dysarthria. Seizures are seen in around 6 to 30% of the patients, and lethargy. We have to keep in mind that plasmacytomas of the spine, base of skull, or sinuses producing local compressive symptoms, hyperviscosity syndrome, paraproteinemia, hypercalcemia, uremia, treatment-related neurotoxicity, stroke, and CNS opportunistic infection can mimic CNS involvement in multiple myeloma. Therefore, any unexplained neurological symptoms at any stage of the disease, prompt evaluation with MRI of the entire neuroaxis along with CSF analysis is warranted to confirm or exclude CNS involvement. Coming to the diagnosis, gadolinium enhanced MRI is the gold standard for parenchymal and leptomeningeal involvement. And it is around 90% sensitive for CNS involvement diagnosis. CSF evaluation is a must for diagnosis. Lumbar puncture is required to confirm clonal plasma cell populations. Cytology and multiparametric flow cytometry will help us in knowing restriction to kappa or lambda light chains. Free light chains in CSF should be interpreted with caution, and emerging biomarkers for CSF evaluation are soluble BCMA and circulating tumor DNA in the CSF. Surgical biopsy and histopathological examination is rarely needed. However, in cases of high index of suspicion with negative CSF findings and no parenchymal or leptomeningeal lesions, dural-based biopsy by neurosurgery may be considered. Coming to the management strategies. So, in CNS involvement of multiple myeloma, we require rapid symptom control. And for this, we need CNS active systemic therapy, intrathecal therapy, radiotherapy for focal or parenchymal disease. Cellular therapy is tried, and a combination of the above strategies is also tried. Intrathecal therapy. Intrathecal infusions of cytarabine or methotrexate, hydrocortisone, or thiotepa based approaches have been used in treatment of CNS myelomas. They have to be administered repeatedly till plasma cells and free light chains are cleared from the CSF. Close monitoring of CSF clearance is essential as myeloma cells are generally not susceptible to methotrexate or cytarabine, and these agents have limited ability to penetrate parenchymal CNS lesions. Intrathecal therapy is primarily recommended for cases with leptomeningeal involvement, and its limited efficacy in the treatment of parenchymal lesions and should not be relied upon as primary modality in such cases. So, intrathecal therapy was being studied by a group of patients and in a group of patients, and it showed that the OS has been improved from 2 months to 29 months by usage of IT therapy. However, best outcomes were seen with combination of therapies. Coming to radiotherapy, Myeloma cells are exquisitely sensitive to radiotherapy. It is usually recommended in cases of parenchymal brain or intramedullary spinal cord lesions with systemic therapy, and doses as low as 4 Gray in two fractions can lead to about 70 to 80% of clinical response. However, a primary concern uh, with respect to radiotherapy is that it can exacerbate the existing cytopenias, particularly in heavily pretreated patients. Large volume treatment, such as craniospinal irradiation, can be used when the entire craniospinal axis requires coverage, or CNS only involvement is there without any evidence of systemic disease, or with otherwise well controlled extra CNS involvement as a bridge to consolidated therapy. Two primary toxicity concerns with craniospinal irradiations are neurocognitive effects and myelosuppression. And this can be largely mitigated and often avoided altogether by using low dosages. However, it should be kept in mind that concurrent use of intrathecal methotrexate and radiotherapy should be avoided due to a potential increased risk of radiation myelopathy. So, conventional chemotherapy has a very limited efficacy due to the resistant clones that emerge after previous therapies, and most importantly, due to inability to cross the blood-brain barrier. Alkylators, which we conventionally use in multiple myeloma, such as cyclophosphamide, melphalan, they lack sufficient CNS penetration. High-dose methotrexate and cytarabine can cross blood-brain barrier, but the efficacy in myeloma is variable. Bendamustine also has shown potential in CNS activity in other malignancies, may offer a modest benefit in selected cases. Multi-agent regimens such as DEXA with PACE, VTD PACE, have included cytotoxic agents with some CNS penetration, such as etoposide and cisplatin. However, their efficacy in treating CNS myeloma remains very uncertain. Dexamethasone forms the cornerstone of treatment. It provides symptom relief in CNS disease through its anti-inflammatory properties, but it lacks direct cytotoxic specificity. Preclinical models suggest that it may reduce peritumoral inflammation and help to restore the blood-brain barrier integrity. So, coming to proteasome inhibitors, marizomib is a novel proteasome inhibitor which has high blood-brain barrier penetration and is the preferred proteasome inhibitor, which forms the backbone of CNS myeloma management. Bortezomib and ixazomib have been regarded as not suitable for active CNS myeloma. However, carfilzomib has a variable limited data regarding blood-brain barrier penetration and can be considered for CNS myeloma treatment. Among the IMiDs, pomalidomide has the highest blood-brain barrier penetration, and there is a strong salvage data to prove CSF clearance and its outcome improvement, and is therefore preferred for treatment of CNS multiple myeloma. It is also preferred for lenalidomide refractory cases. Thalidomide and lenalidomide also have moderate to high uh, blood-brain barrier penetration and can be used in the management of CNS involvement. Coming to anti-CD38 antibodies, daratumumab and isatuximab, they have poor CSF penetrance and therefore are not recommended for treatment. Selective inhibitors of nuclear transport, that is selinexor, has blood-brain barrier penetration in preclinical and clinical models, including STORM, Boston, and STORM trials. These trials included heavily pretreated patients with systemic myeloma, and signals from these trials showed a trend towards improvement in overall response rate and of PFS. In fact, a prospective trial is which is testing selinexor, pomalidomide, and dexamethasone exclusively in patients with CNS myeloma has been started. Coming to the cell mods, the immunomodulators bind to cereblon substrate receptor within the CRL4-CRBN-E3 ligase complex, which alter the substrate specificity and promotes the degradation of transcription factors such as Icaros, which is IKZF1, and Iolos, IKZF3. both of which are critical for survival of myeloma cells. Cell morphs such as iberdomide, avadomide, and mezigdomide (CC885) are next generation CRBN targeting molecules which are more potently effective at degradation of these transcription factors. However, they are under active evaluation in patients with CNS involvement. Coming to venetoclax, it is a selective BCL2 inhibitor which shows efficacy in patients with relapsed refractory multiple myeloma harboring the translocation 11-14 translocation. It is shown to penetrate the blood-brain barrier in pediatric leukemia patients. However, its potential activity in CNS myeloma remains unknown due to lack of available data. Coming to the emerging therapies, which are the CAR-Ts and bispecifics. So it is very interesting to know the mechanism of blood-brain penetration in immunotherapy. A systemic stimulus often activates peripheral inflammation, which leads to immune cells releasing the pro-inflammatory cytokines such as TNF alpha, interleukin 6, interleukin alpha, interleukin 3, interleukin 2, and interferon alpha, which increase the sensitivity of blood-brain barrier and leads to disruption of the blood-brain barrier. This can lead to two pathways now. It can have adverse effects which leads to increased risk of severe neurotoxicity, or the increased permeability like they can prove to be of therapeutic opportunity, leading to entry of the CAR T cells and bispecific antibodies which enter the CNS because of the increased permeability of blood-brain barrier due to inflammatory responses, and then they target the plasma cells in the CSF. So, CAR-T, BCMA CARTs have excellent activity in relapsed refractory disease, but the role in CNS myeloma is unclear. Most clinical trials exclude patients with active CNS involvement. Gabala et al. Has published the largest dedicated series to date cohort of myeloma patients with CNS disease in receiving BCMA CAR-T therapy. So 10 such heavily pretreated patients with median of 6 prior lines of therapy were studied in this series with almost 100% had MRI confirmed CNS involvement, 40% had CSF positive disease, and around 60% of these patients received ID cell and 40% received Silta cell. So the overall response which was seen was around 80% with a CR of 60%. And median OS was 13.3 months and median PFS was of 6.3 months. Reviewing the safety profile of CAR-T in CNS involvement, there was no more than grade 3 CRS. Grade 3 ICANS was seen in around 10% and there was no grade 4 ICANS. There was also no Parkinsonian neurotoxicity, thus proving that BCMA CAR-T is feasible, active, and does not cause any excess neurotoxicity in CNS myeloma. However, in view of short PFS, there is a suggestion that post-CAR-T maintenance would help. Bispecific antibodies such as teclistamab, talquetamab, and elranatamab are smaller molecules than CAR-T cells, but have better blood-brain barrier penetrability, although the clinical data remains limited. So, in a series of 9 heavily pretreated patients, talquetamab was given for 8 patients and teclistamab was given in 1 patient. All these patients had CNS involvement, and CNS response was seen in all 6 evaluable patients. They achieved VGPR or better systemically. So bispecifics may offer rapid off-the-shelf disease control in CNS multiple myeloma, but prospective validation is needed for bispecifics. Coming to transplant, autologous stem cell transplant remains a standard in newly diagnosed myeloma, but offers limited benefits in patients with extramedullary disease or CNS involvement. Poor outcomes may reflect early relapse due to high-risk disease biology. Stem cell transplant can overcome the poor prognosis of extramedullary disease when detected at diagnosis and can have a similar effect in extramedullary disease as in bone marrow relapse, contradicting the theory that extramedullary disease has its own immunological environment that will not support a graft versus myeloma response. However, unlike in extramedullary disease, stem cell transplant is not currently considered a standard salvage treatment option in most cases of CNS myeloma due to their short survival time. So, this is the armamentarium used in CNS involvement of myeloma. Our age-old and standard intrathecal therapy consisting of methotrexate, cytarabine, and thiotepa, radiation for focal lesions, or craniospinal irradiation, wherein CNS only is involved. Then conventional chemotherapy of bendamustine and nitidigase, molecules such as imids, pomalidomide, lenalidomide, and thalidomide, and venetoclax, and the emerging therapies such as BiTEs, teclistamab, elranatamab, talquetamab, and the CARDs, BCMA CARDs, siltazol and IDC. There are few unresolved questions in the management of CNS myeloma. Despite this expansion in the arsenal of myeloma therapy, CNS involvement remains a therapeutic blind spot. Lack of agents with validated CNS efficacy and need of CNS penetrant immunotherapies poses a challenge. Integration of biomarkers such as CSF-based circulating tumor DNA and soluble BCMA for earlier diagnosis and to guide future treatment approaches, and also trial inclusions of CNS myeloma patients. So, to summarize, in any patient with unexplained neurological symptoms at any stage of uh, disease, with high index of suspicion, MRI of the whole neuroaxis should be done and CSF examination should be suggested. On MRI, we might see leptomeningeal enhancement or thickening, dural enhancement, intraparenchymal lesions, intraspinal lesions, or nodular meningeal tumors. On In case of CNS involvement of myeloma, CSF examination will reveal clonal plasma cells and free light chains. And on the diagnosis of CNS myeloma, we might subject the patient to systemic chemotherapy with drugs crossing the blood-brain barrier, corticosteroids, and give an option of transplant. Or if any clinical trial is present, if available, we should enroll the patient into a clinical trial. And other potentially active therapies such as anti-BCMA bispecific antibodies or CAR T cells should be used, and agents such as immunomodulators, proteasome inhibitors, selinexor, and anti-CD38 monoclonal antibodies are used. Along with IT chemotherapy and radiation therapy, response assessment is usually done by repeating MRI and by CSF evaluation. So to conclude, CNS involvement in multiple myeloma remains underdiagnosed, especially in patients with relapsed disease and subtle neurological symptoms. Strongly associated with high risk cytogenetics, plasmablastic morphology, elevated LDH, and extramedullary disease. Pomalidomide based therapies, radiotherapy, and intrathecal chemotherapy remain the most widely used treatments, but response durability is very limited. Traditional monoclonal antibodies and proteasome inhibitors have limited CNS penetration. Emerging therapies such as CARs and bispecific antibodies are promising but are understudied. Individualized multidisciplinary management is required till trials expand. So this was my take on CNS myeloma. Thank you.
Thank you, Dr. Jyoti. So I do agree, CNS involvement in myeloma is pretty challenging, considering the rare amount of involvement, and that most of our clinical trials exclude patients with CNS involvement, and there is no mature data to tell us what to do. It is difficult to manage. I hope in the future we get some better data and there becomes a standard of care what to do when we have a CNS involvement in myeloma. So thank you, Dr. Jyoti. Oh, so let me welcome Dr. Nutan Joshi, Dr. Mopali, and Dr. Nakul. I couldn't welcome them because they joined a little bit late. So our next talk would be by Dr. Nakul Tikare. Dr. Nakul is a consultant in clinical hematologist and consultant clinical hematologist, hemato-oncologist, and BMT physician at Manipal Hospital, Goa. And from CNS myeloma, the other difficult to treat myeloma is EMD in myeloma. And Dr. Nakul will be delivering a talk on EMD disease in myeloma. Over to you, Dr. Nakul.
Thank you, Dr. Jay. I'm trying to log in and get the slide up.
Yeah.
Can you see the video? Sorry, the PPT. Are you
Right.
able to see?
Right now, we are not able to see Dr. Nakul. Yes, now we are able to see it.
Okay. Can you see it on full screen?
Yes, we can, Dr. Nakul.
Okay. Thank you, Dr. Jay. I am Dr. Nakul. I'll be talking about extramedullary myeloma. After the difficult talk of CNS myeloma, this is one more aspect where it is very difficult to treat, and we have come across varied presentations in our clinical practice. I'll be going roughly quickly from the molecular pathogenesis to our advanced immunotherapies and management. Coming to definition, it is basically a presence of clonal plasma cells at anatomical sites outside the bone marrow and microenvironment. It represents an aggressive variant of myeloma where cells have developed a bone marrow independence. Now, there are two aspects when we look about extramedullary disease. One is true EMD or something called as paramedullary disease, where it is basically a contiguous expansion of marrow plasma cells adjacent to the bone through cortical destructions into a extramedullary space. Previously, these were like six types of EMDs we were going about. One was solitary plasma cytomas with minimal marrow involvement, bone associated EMDs, bone independent EMDs, organ infiltrating EMD, or plasma cell leukemias. Right now, plasma cell leukemias are something that we look as an independent entity. We are not actually looking in the same aspect as EMDs, but the management is more or less in a similar aspect. This is what I meant to say by EMDs and paramedullary disease. When we say soft tissue EMDs, it basically on the top right, it is non-contiguous with bone, most commonly usually in soft tissues. Paramedullary is basically bone into the soft tissue outside, and organ associated is basically organ infiltrations. How does how does this develop? Basically, it is a clonal evolution, which is one of the triggers. And then there are some other triggers, which is basically going to act on bone marrow dependence and immune surveillance down regulations. The details I'll explain as we go ahead with the slides. Now, this is what I said, true EMM to soft tissue plasmacytoma, they result from hematogenous spread with no contact with bony structures. Paraosseous or paraskeletal disease are often excluded from the strictest EMM definitions. Basically, EMM is an independent adverse prognostic factors associated with the ultra high risk of early progression, disease-related deaths. True EMM is roughly around 0.5 to 5.2% in incidence. Primary at diagnosis, newly diagnosed is 0.5 to 4.8% of the patients. And secondary EMM is usually 3.4 to 14% at relapse. And some sources suggest it can be up to 30% across the disease course also. Now, as we treat from 2005 till today, there has been an increase in EMM prevalence right now. Most of the things are because of the improved survival with novel agents, use of anti-CD38 now, anti-bispecifics, CAR-Ts. We are getting more and more prevalence of the disease, and that makes it more of relapses and more of diagnosis of EMMs. Just a brief about PCL, it can be identified at diagnosis, usually on 0.6% of myeloma cases, and secondary PCL with a median time from myeloma diagnosis to leukemic progression is usually around 20 to 22 months. What is the timing? Usually time from myeloma to a secondary extramedullary myeloma occurrence is 19 to 23 months. Uh, there is no conclusive evidence of some case reports where it is told that it can be triggered by invasive procedures like surgery, catheter insertion, or bone fractures. A median age for bone independent EMD is roughly around 60 and a half years, lower than that for bone associated EMDs, which is around 71 years. Secondary EMD is linked to extensive prior therapies, roughly more than 2 lines, and allogenic transplants. What are the typical sites of involvement? Usually it's the skin, muscle, soft tissues. At relapse, it's visceral organs like liver, kidneys, pancreas, CNS, pleura, breast, pericardium can be involved. At diagnosis, mainly we come across head and neck EMMs. CNS myelomas, like Dr. Jyoti said before us, meningeal infiltration, intraparenchymal diseases can be there. Plasma cell leukemias is, we know the definition, more than 5% of clonal plasma cells or absolute count of more than 500 in the peripheral blood. What are the risk factors? Coming to risk factors, usually a translocation 14, 16, IGS translocation with 16 and 20, a development of a high risk genetic lesion like 17p deletions, 1q abnormalities has been associated with development of secondary EMDs. Now, few studies have also reported associated high risk cytogenetics such as 414, 14, 16, 1q gain, deletion 17p in patients with EMD with at least one high risk abnormality present in diagnosis in over half of the patients with EMDs. There is one ZEC and Steiny studies where they have corroborated without any genetics involved, younger age groups, high LDH levels, extensive osteolytic activities, IgA type of myelomas, and non-secretory type of myelomas, which can be present as one of the risk factors for EMDs. This is what I meant to say. A marrow dependent, which is confined to the bone marrow. It follows standard CRAB criteria, high CD38, 56 expression. It is marrow dependent. On the right side, suddenly there is an escaped clone, marrow independent. There is loss of adhesion molecules. There is immune evasion and high risk cytogenetics involved over here. What is the bone marrow escape mechanism as per that previous diagram? It requires transition from to the EMD from as a detachment from the bone marrow in microenvironment. So there has to be some loss of anchoring and there is adhesion molecule dysregulation involved. And coming to the adhesion molecule dysregulation, here there is downregulation of NCAM, that is CD56, which normally anchors the plasma cells to the bone marrow stroma. Also, there is VLA4 dysregulation where ablation redirects tumor spread into the extramedullary spaces. There has been research which suggests upregulation in CD44, 81, and nestin, which facilitate migration to the extramedullary spaces. This is the genomic mechanism of marrow independence and cellular dissemination, downregulation of adhesion molecules, like I said, CD56, VLA4. There is disruption of CXCR4 and STF1 alpha in the bone marrow homing axis, upregulation of ROBO1, ROBO2 alterations. These things promote migration into extramedullary space. There is marrow dependent state to microenvironment escape and marrow independent dissemination. And then next on the right side, there are some triggers which are involved, which helps in which causes genomic complexities like MAPK pathway, NRAS, KRAS, BRAF mutations in almost 94% of the cases. And there is high risk cytogenetics, like I said, and elevated tumor burden is also one of the risk factors. This is again a reiteration of what I previously told. Uh, I said about genomic landscapes. Here there is MAPK alterations where I said more than 94% MAPK pathway alterations are occurring for extramedullary diseases. And in EMD, almost there is a tumor mutational burden present. And EMD survival and proliferation are directly driven by constant RAS and BRAF signaling, rendering them independent of the bone marrow microenvironment. Again, the same thing. Biallelic tumor suppressor loss, which can happen in MAX mutations, alters make heterodimerization, disruption of cellular homeostasis, CDKN2C biallelic loss in 17% of the cases. On the right side, we straight away come to mutations in many of the genomic factors, which remodels the chromatin landscape to alter plasma cell identity and down-regulate marrow dependency genes. This is roughly the pathogenesis of extramedullary spread, downregulation of chemokine receptors, adhesion molecules, and tetraspanins, and activation of MAPK pathways and angiogenic cytokines. Hypoxia and epigenetic factors also, hypoxia also promotes dissemination through acquisition of EMT-like features, and MALAT1 is high level of this non-long coding, non-coding RNA, sorry, are associated with EMM spread and poor prognosis. Now, how do we come across diagnosis? It presents with atypical or unusual symptoms depending on the organ involvement, maybe headache, epigastric pain, ataxia, if it is CNS involved. It requires a pathological confirmation via biopsy. FDG PET is the gold standard, detects metabolic activity, monitors response to therapy. Dual criteria is recommended. Whole body MRI with diffusion weighted imaging is optimal for detecting leptomeningeal involvement and spinal cord compression. It also reflects tissue cell density, useful when PET findings are little hazy or unclear. These are how we go across the investigation comparisons. Prognostic relevance, if you go to see FTG PET, for prognostic significance for focal lesions and number and SUV values. When it comes to MRI, prognostic significance for focal lesions and diffuse pattern is there. MRD evaluation is recommended, and utility, we all know how we utilize this PET and MRI and low dose CTs. What is the difference in immunophenotyping between normal not normal, means multiple myelomas and extramedullary myelomas? Now here, when I say green, it is upregulated. In extramedullary myelomas, CD44, Nestin 31 is upregulated. Usually, as we can say, CXCR4, CCR2, CD56, 19, 20, 27, these are down regulated compared to the myelomas. And coming to genetics, there is increase in EZH2 expression, 1q deletions, MAPK mutations, like how we said. CD70 expression is also increased. Biopsy features markers, we all know about CD138, MUM1, and CD38, which are useful for identification. Red flags on our routine evaluation: elevated LDH, light chain escapes, disappearance of intact M protein with an increase in free light chain. We have to look for any extramedullary myelomas. Cytogenetics, we all know about performing FISH to see for clonal types and special differences, and high frequency of these IGH translocations and 17p deletions. This is mainly on treatment, how we go about to monitor next generation flow and next generation sequencing in marrow can be done. We would all prefer a double negativity, basically bone marrow MRD negativity with metabolically negative PET scan is what we would ideally prefer if it is a myeloma with an extramedullary involvement also. Let us go to the treatment aspect now. This is how we have evolved in treatment of myeloma over the years, right from melphalan almost 7 decades back to right now we are going with CAR-Ts and bispecific antibodies. And in between also the IMIDs, the proteasome inhibitors, and the anti-CD30s massively changed our way of treating myelomas. Now, coming to myeloma versus extramedullary myeloma, let's go agent by agent. Frontline agents, if you go at proteasome inhibitors, bortezomib, carfil has a very good efficacy for an extramedullary disease. It retains extensive tissue penetration, recommended as foundational induction therapy, can induce rapid EMD regression. Compared to that, let's come to Carfil or Ixazomib, shows lower clinical benefit in response to in EMDs, higher rate in true non-responders. Ixazomib lacks a strong data for EMD benefit. Among the IMIDs, thalidomide is usually ineffective in cases of extramedullary. They usually have a response, but then there is quick loss of response. And Len and POM provides a good response up to 83% ORRs in some of the small cohorts, and pomalidomide, as the previous colleague Dr. Jyoti suggested, it also crosses the blood-brain barrier. The modern targets anti-CD38, DARA, isatuximab, EMD clones frequently downregulate CD38. So DARA as a monotherapy will show a limited efficacy. Overall response rates of only around 16 to 24%. Isatuximab combined with POMDEX, ISA-POMDEX significantly improves the PFS of around 4.5 months versus only 1.56 months. And let's come to elotuzumab, lower SLAMF expression in extramedullary sites. These explain the poor outcomes. Overall response rate comes to almost around 40% in EMD compared to standard myeloma. And then there is selinexor. It's very active in penta-exposed triple class refractory EMDs by preventing export of tumor suppressor proteins. Selinexor is very good in CNS penetration. That's what we came across in the previous talk, and that is something which can be definitely tried in cases of CNS involvement. Now, once we come across bispecifics and CAR-Ts, what do we mean by this graph? There is initial response is really good. Overall response in CAR-T is almost 58 to some cohorts with 88%. Here the catch is median progression-free survival is severely curtailed. For example, 5 months in extramedullary versus 11 months in non-EMDs. Tumors usually melt away, but escape clones and rapidly emerge at new sites. So there is a good response, but then there is a truncated PFS, and we don't get a sustained disease-free time. Same thing with bispecifics, similar paradigm as CAR-T. Talquetamab yields a comparable ORR, but median PFS drops from 8.3 to 4.3 months in soft tissue EMDs. How we go about the treatment algorithm? First thing, achieve deep hematological response, EMD lesion resolution. Treatment varies by transplant eligibility and site of disease. Primary EMD in cases of transplant eligible patients will go by a triplet or quadruplet regimen. High burden strategy use intensive cytotoxic containing regimens like V or Carfil, DR pace. Primary EMD management in transplant ineligible will be like a VMP or a VRD. Continuous Lendex. Addition of DARA is considered rational in this case. Secondary EMD management options are limited. Participation in clinical trials are mainly preferred. POM-based combinations, CAR-T bispecifics are usually good acting. We can use local therapies like surgery or radiotherapy for a compressive or a symptomatic lesions. Always there has to be a consolidation in AST. Tandem ASCT recommended for high-risk patients to improve survival over a single ASCT. This is what I said before. Bortezomib has a high tissue penetration. Carfilzomib response rates are high, 83% in combinations like KRD, but the duration of response is shorter. So quickly go ahead with transplant once there is response. Thalidomide generally ineffective. Len overall response is around 61% when combined with Dex. And POM standard Len refractory cases combination with bendamustine has shown a promising activity. Selinor is an XPO1 inhibitor approved for penta-refractory myelomas. STORM study in the subgroup analysis, selinexor with DEXA is active in visceral EMDs with an overall response rate of 18.5%, but benefit remains suboptimal as monotherapy. These are some of the site specific EMDs, how we go about treatment and what are their incidences. CNS involvement is roughly in 3% of the cases. Skull orbit vertebra less than 1%, breast is almost 9% of the primary EMDs and 3% in secondary EMDs. Thyroid in 2.9%. Coming down straight away to spleen is 9% again in primary EMDs and 11% in secondary EMDs. And let's go down one more, liver, presenting as hepatomegaly, jaundice, ascites, fulminant liver failure, elevated OTPTs. Almost 28% as the incidence in extramedullary myelomas. And lymph node, we all have come across lymph node involvement, non-tender, enlarged lymph node, weight loss may be present. Common site is paratracheal lymph nodes, almost present in 23% of extramedullary myelomas. How we go about is basically the CNS wise will be a whole brain RT, intrathecal chemotherapy, systemic chemotherapies. The treatment varies on the site involved. Advanced immunotherapies, CAR-T, primarily BCMA, ID-captogene, cilta-captogene, autoleucel is approved now for myelomas. We all come across this high initial responses, but often short-lived in secondary extramedullary diseases. CAR-T outcomes in extramedullary myelomas as per KarMMa 3 data, PFS is only 5.3 months for EMM compared to 11 months of non-EMM patients. MRD, 40% of EMM patients can achieve marrow MRD negative, yet still progress extramedullary. So, and BITES, teclistamab, talquetamab, lower efficacy as monotherapy, teclistamab only 35%, monotherapy significantly lower than the relapse refractory, general relapse refractory myeloma population of where the response is almost 63%. So all these concepts are falling flat on our face because there is a good initial response, but there is very short-lived persistent responses. And here now we have come across a dual target strategy. We all came across this NEGM study, redirect one study, where it shows where we have basically combined GPR C5D and a BCMA bispecific together, because both are expressed in the extramedullary sites and targeting both, and there is a dysynchronous expression of these uh, markers on the tissue. So combining them had shown an encouraging overall response rate of almost 61 to 71% in extramedullary myeloma patients using dual targeted bispecifics. Isatuximab along with Pomdex, there is again a 4.5 month versus 1.5 months survival benefit in EMM compared to PD alone. It inhibits CD38 enzyme activity, translating into a better EMM. Somehow isatuximab data-wise has got a little better PFS figures compared to daratumumab here. And DARA in combination with DCEP receives, and this is little encouraging, overall response rate of around 67%. Elotuzumab, lower expression of SLAMF7 in extramedullary sites, so the response are usually poor. A transient response, overall response of around 40%. Belantamab, duration of response impact, extramedullary myeloma is the sole prognostic factor, significantly impacting both PFS and OS in real world cohorts. Overall response rate in extramedullary myelomas is only 23 compared to 40% overall. These are some of the outcomes of many diseases and various combinations. What are our PFS and overall response rates? DARA VCD, once we combine in newly diagnosed, has an overall response rate of 80% with a PFS of 26, and newly diagnosed versus 15 months as relapse. There are multiple agent regimens like ASCT, MP, RD, TD. All these come to approximately 2-year overall survival of only 50%. Coming down here, there is a bendamustine with pomalidomide dexamethasone in relapsed refractory myelomas, where they have studied true as well as true as well as paramedullary myeloma diseases, and overall response rate is around 54% with a 2-year PFS of around 71% and overall survival of almost 82%. POM Ixadex is also having an overall response rate of 35% here. Let's come to the second combination there, VD paste with IMID. Has an overall response rate of almost 76% with a PFS of 5.5 months. And DT paste DARA DCEP has a ORR of 25%. In if you consider all EMDs, overall response rate of almost around 68%. Elotuzumab based combination therapies, as I said, overall response rate is only 40% here. And Pomdex, Daradex, not a very encouraging figures over here. Now, these are some T cell directed bispecific agents over here where, sorry, these are some CAR T therapies which have been found out and with their with their efficacies. Uh, Coming to Cilta-cel and ID-cel, we had an overall response rate of almost 58% in EMMs versus 96% with no EMMs. However, the PFS is only 5.1 months compared to 1 year almost in no EMM. Same things it across the studies with regards to Cilta-cel and ID-cel. And the second last is about the Karma, where they saw the ID cell had an overall response rate of EMM worse than no EMM. There's no specific data here mentioned in the trial. The Cartitude trial with Cilta-cel also had an overall response rate of 60% in extramedullary myelomas. These are some of the Chinese data that I came across where they found investigational therapies of T cell directing anti-BCMA CAR Ts, where they had an overall response rate of almost 84% in EMMs. And these are all phase 1, phase 2 data. Here they had a murine anti-BCMA CAR T with an overall response rate of almost 92%. And here there is 100%, but we need more figures and more data as we go across time. Coming to bispecifics, teclistamab, talquetamab has a overall response rate of almost around 40% in across various studies. Majestic 1 had an overall response rate of around 58% for extramedullary myelomas with teclistamab. What is the mechanism of resistance to immunotherapies? Basically, there is a down regulation of CD38, so we cannot wholly depend on anti-CD38s, down regulation of GPRC5Ds, so we cannot go ahead with those monotherapies. And there is an exhausted T cell, enrichment of TIM3 and PD1 in T cell in EMM microenvironment. There is an exhaustion of T cells. So relative deficiency of those targets and T cells are also there. So that all is hypothesized to come to a conclusion that there is reduced responsiveness of all these medicines, which are very well acting in myelomas normal. Site-specific management, CNS, Dr. Jyoti had discussed quite in detail. I have just 2 lines over here. Usually it's 1% in incidence as extramedullary, median OS of less than 6 months. Worse for leptomeningeal than osteodural involvement. Targeted therapies, we all have come across, so I won't go more into this. High penetration of THAL, POM, and marizumab is there. Low penetration with LEN and BOT. Coming to myelomatous pleural effusion, we use systemic therapies, and I've come across one patient where we have used intrapleural bortezomib and had shown a good result. These are all based on case reports. Pancreatic involvement usually presents with light chain escape. You have to use PET scan as monitoring response in this visceral site. Spinal cord and soft tissue, you go as per local RT with the systemic therapy. How do we follow up MRD and outcome? Prognostic summary. Median OS for primary EMM is 3.6 years versus 7.1 years. And median OS for relapsed EM is often less than 6 months in historical cohorts. Factors correlating with poor PFS or OS, multiple organ involvement, bone independent, that is secondary extramedullary disease spread worse than bone extramedullary disease, elevated serum ferritin at lymphodepletion during the CAR-Ts are also one of the risk factors correlating with poor PFS and OS. How do we come across as standard assessment guidelines, we use PET CT or MRI 3 months after starting treatment. Use the same imaging modality through the clinical course to ensure consistency. MRD and imaging integration is required. Let's come across some therapies with bortezomib, POM. We have come across these figures for relapse refractory and some few studies for the upfront newly diagnosed EMDs. This is in brief how we go about primary and secondary EMDs. Primary EMDs, you go ahead with an induction. If it is transplant eligible, triplet regimen with RVD, KRD, PAD, RVD or daratumumab and V or K DR pace. You go ahead with an ASCT and then consolidation. Continue initial regimen for 2 to 4 cycles and go ahead with the maintenance PI plus IMID until progression or intolerance. When there is a transplant ineligible state, RVD, DARA MPV, DARA VCD can be given. You continue therapy followed by maintenance. Coming to secondary EMDs, you go ahead with the polychemotherapy regimen like DT PACE, DCEP, Dexabeam PACE. CAR-T is an option. Novel agent combinations like POM-VD, ISA-POM-DEX, selinexor, dexamethasone, or bendamustine POM-DEX is also there. Of course, if there is no scope or due to finances or poor performance status, you go ahead with the RT for a palliative care. How do we come across CNS myeloma? We have come across this in detail for last half an hour by Dr. Jyoti. I wouldn't retreat more into this. Bortezomib has a 5% CSF to plasma ratio. Len has 11%. POM and marizomib has 39 and 30% CSF to plasma ratio respectively. These are the ultimate sanctuary sites. CSF, same thing what I said before, CNS myeloma occurs in almost 0.6, 0.7% of the patient. Median overall survival plummets to almost 40 months compared to 93% in non-CNS. Standard CAR-T protocols currently exclude CNS invasions. In secondary myelomas, secondary EMDs, relapse refractory, how we go about, you have an option of down. If you go from down to top, lymphoma like polychemotherapy, bridging or debulking, regimens like PACE, DT PACE, DCEP, Dexabeam, rapid disease control, though short duration of response, less than 4 months. Novel agent combinations, ISA POMDEX, POMVD, CELDEX, Benda POMDEX, utilizing third generation IMID CD38 XPO1 targets for sustained response, or there is CAR-Ts and bispecific, provides deep, rapid remission, best utilized as bridge to allo-SCTO or continuous novel maintenance. This is more or less how we go across the survival curves of EMD versus non-EMDs. ID cell Karma 3 median PFS on the right side, you can see 5.3 months versus 11 months, median OS of 14, almost 15 months compared to 27 months. So it's basically half of what we want. CAR-T is a double-edged sword. Again, there is less response compared to non-EMD disease at day 360, which comes to almost 7 compared to 72% in non-EMD, it is almost 28% in EMDs. And if you go for a 360-day OS, then the day 360 non-EMD is 81% compared to 28.6%. So take away from this slide, rapid deep remission, but spatial heterogeneity and TME barriers in extramedullary sites often prevent durable eradication. Now, coming to bispecific, we came across all this BCMA targeting teclistamab, elranatamab, GPRC5 targeting with talquetamab. The game changer is basically, I feel now, is dual targeting innovations with redirect one trial data with Taltec, teclistamab with talquetamab. And then there is a role of ASCT. The core question remains, can high dose ASCT overcome the adverse prognosis of AMDs? If it is transplant eligible pathway, overall survival impact, ASCT bridges the gap in newly diagnosed, that is a 2-year overall survival is 82.9% versus 84.7% in non-EMDs. If it is a complete response gap, post ASCT CR rates remain significantly lower. in terms of EMDs, which is 36 versus 90%, leading to inferior long-term PFS. So how can we do a strategic variation from this? Tandem ASCT strategy significantly improves survival in EMD patients with high-risk cytogenetics, extramedullary soft tissue or bone involvement. ASCT demonstrates greater relative efficacy in soft tissue group compared to the bone-related group. This is the CAR-T paradox. Like I said, non-EMD high durability, EMD low durability. Initial strike, anti-BCMA CAR-T therapies have a rapid deep remission with an overall response rate of almost 71 to 88%. But there is a durability failure. Day 180 PFS OS remains statistically similar between EMD and non-EMD. But at day 360, the curve breaks and PFS drops dramatically from 72.5 in non-EMD to 28.6 in EMDs. So this is what we have come across bispecific arsenal. Now, what is the breakthrough countermeasure? Dual bispecific targeting. You target with both talquetamab, teclistamab. It combines to combat the high genomic microenvironment complexity of a true EMD. Overall response rate of 61%, specifically in true extramedullary myelomas, and durability is almost 82% of a 12-month duration response. So when we come across the redirect study, the combination of Taltec has demonstrated high efficacy for patients with true EMDs, that is significantly outperforming results seen with either agent used as monotherapy. The efficacy metrics updated from the 2025 ASH and NEJM report, overall response rate of around 79% with true EMD achieved a response. This is a markedly higher than the normal response rate reported for monotherapies, whereas teclistamab achieves approximately 35% and talquetamab achieves only 45% of in EMD populations. Depth of response, 54% of the patients achieved a complete response or better. PFS was almost around 15 months in comparison to like 3 or 6 months in monotherapies. And overall survival at 12 months was almost 74%. And post-CAR-T performance, the combination achieved a 83% response rate in subgroup of patients who had previously failed BCMA-directed CAR-T therapies. Coming to safety and toxicity, we come across CRS when we give teclistamab. It occurred in almost 78% of the patient. Grade 3 or 4 infections happened in 31% of the patients. 5 TRMs were there, all attributed to infections. And oral symptoms, dyschezia, dry mouth, dysphagia were common, affecting 87% of the cohort. So what are the clinical consideration? Utilize the strict definition of true EMD, focusing on soft tissue plasmacytomas non-contiguous with bone, which typically carry the worst prognosis. However, caution is advised in interpreting these results because study was a single arm trial with a relatively short median follow-up of 12.6 months. Additionally, patients with CNS involvement and plasma cell leukemia were excluded from the trial, leaving the efficacy of this combination undefined for those specific high-risk groups. Let's come to the meta-analysis of CAR-T versus bispecific. It's basically the same data in a different format here. Overall response rate is almost around 0.77, 0.6 in bispecifics, but durability is a question. How do we come across toxicity management once we start with immune therapy? That's a different topic in itself. But in brief, if I go to see, we have to be prepared for the management of cytokine release syndromes and ICANS. Rapid massive lysis of solid tissue compartment triggers severe systemic inflammation. That's basically a definition of CRS. Acute onset of CRS, you can utilize tocilizumab, high-dose corticosteroids. In late stages, we have to come across profound cytopenias, opportunistic infections, requires extended prophylactic antimicrobials and IVIG supports. Coming with all of this, still there might be any mechanisms of immune response through all these mutations. So it remains a continuous challenge for us to address extramedullary diseases. Coming to conclusion and summaries, is an ultra high risk phenotype requiring multidisciplinary coordination. Advanced immunotherapies like BiTEs and CAR-T are effective but not yet curative for the extramedullary compartment. We require urgent prospective trials dedicated solely to EMM endpoints. So coming to extramedullary disease, aggressive cytoreduction, lymphoma like polychemotherapy, you use novel combination agents, cellular interventions, palliative support. This is in brief the management. What are the future directions and novel target agents? Next gen antigens like exploring SLAM F7 in a more detailed manner, FCRH5 dual antigen CAR constructs to prevent antigen escape. We can look upon the adhesion and migration inhibitors targeting ROBO1-2, which alters the ROBO1-2 alterations to physically prevent myeloma cells from migrating and adhering to extramedullary sites. Then there is an epigenetic reversal overcoming the fixed high-risk genetic states like 1q amplification through targeted epigenetic modulations or TME modulators, combining various immune effectors with agents that reverse hypoxia or inhibit PI3K AKT pathways. These are more across other future horizons, redefining the EMD paradigm. These are my references. Thank you.
Thank you, Dr. Nakul, for your comprehensive overview on EMD management in multiple myeloma. So the data for secondary EMD, the TalkTech data, along with dual CAR-T, is pretty good, much more better than all the other data. But still, giving talquetamab and teclistamab together, I mean, it is going to be difficult. So it's going to be
Yeah.
the dual CAR-T. It would be nice to have some real world data regarding both these regimens, the dual CAR-T and TalkTech together, and see how it goes.
Yeah, I agree. It's good for theory, but
Yes,
finances
practically.
is a major limiting factor for that. And also the patient understanding readiness to come for OPD follow-ups because of the severe infections and all which can follow
Yes,
with that.
yes,
It's
yes,
a challenge in itself.
yes. Real world data would really help.
Great.
Yes, thank you, Dr. Nakul.
Thank you.
So after both the difficult to treat myelomas, now we'll proceed to a panel discussion of myeloma itself. Screen. Is my screen visible?
Yeah, it's visible.
It's
Okay,
visible.
great. So we are going to have a panel discussion on multiple myeloma. Our panelists for today are Dr. Devyani Surange. Dr. Devyani is an associate consultant in hematology, hemonc, and BMT at Fortis Memorial Research Institute, Gurugram. Our second panelist is Dr. Mopali Ghosh. She is a consultant, hematologist, and BMT physician at Saroj Gupta Cancer Center and Research Institute, Kolkata. Our third panelist is Dr. Mihek Trihan. She is also an associate consultant in hematology and oncology and BMT at Fortis Memorial Research Institute, Gurugram. And last but not the least, our last panelist is Dr. Nutan Joshi. She is an associate professor in the Department of Hematology at CMC Vellore. I welcome all four of you. I would also request Dr. Jyoti and Dr. Nakul, if they're still there, they could still join in the panel discussion. It will be really helpful. So why all these panelists is because all these of my panelists are very young and they are obsessed. They love myeloma as a disease. And I truly believe in the future, in the next 20 years, they would be one of the top myeloma specialists in India, if not in India and all over the world. And they would be deciding how to manage multiple myeloma. So thank you everyone for joining. Let's start. So this is one of the cases which we had seen in KM. He was a 29-year-old lawyer, no comorbidities, denies any addictions. He presented so this was 20 years back. He presented with backache, paraplegia, and AKI needing hemodialysis. CBC was normal. He had a creat of 10.8, hypercalcemia, albumin was 3.5. On MRI, he had some wedge compression fractures of L2, L4, D5, and D8. Biopsy showed 13% plasma cells. He had a monoclonal band and a beta microglobin of 53. CK was 46XY, it is normal. Diagnosed with multiple myeloma, IgG kappa, IS is stage 2. My first question to the panelists are, what is your preferred modality of imaging in the case of multiple myeloma? Second would be, what are the baseline genetic tests which one orders in multiple myeloma? And the third, how would you define a high-risk myeloma? We could start with Dr. Devyani.
Yes. Coming to the first question, I would say the gold standard and preferred modality is definitely a PET CT. But if finances are a constraint, then yes, a low dose whole body PET will be recommended.
Okay.
Coming to the second, so the baseline genetic tests, we go for chromosomal 14 translocations. Uh, there are also other mutations like TP53, KRAS and RAS, MYC translocations, and now the chromosomal 1 abnormality, which is defining the high risk that is there. So it is all covered in the genetic myeloma panel testing. And yes.
Yes. So I just wanted to know, Dr. Devyani, you all do only a FISH for myeloma at baseline, or would it be other tests also?
So fish as well as NGS, but fish myeloma is a must at least.
So we do FISH for myeloma 100%. NGS is not everywhere. It's not standardized everywhere.
Yes.
So
Yes.
anyone else would like to put in their thoughts regarding this? The baseline genetic test in myeloma?
So NGS, I'm not sure of the actionable part. If it is actionable, definitely we'll go ahead with doing that. Yes, there have been like panels now which will detect the NRAS, KRAS and all that.
Right.
But yeah, the actionable part is still not answered. So when the patient is pending, we need to justify that part. So that part is little difficult. If we
I
are
think
in like a research setting, probably we can go ahead with doing it, but not as a routine practice.
so. I think NGS we do offer to our patients young myeloma, something extraordinary we are seeing, but for TP53 we need that because it won't be picked up on fish per se. One. Second, there's some role of RAS inhibitors, tramitinib, and all there are trials coming up that can be picked up, especially if we are suspecting that the course may not be that good in the future. At the baseline, yes, and then at the follow-up, clonosec as a part of NGS MRD we do.
Oh.
Tends
Oh,
to
so
come.
I would like to have a question because from our setup for most of the patients we are doing this fish, so not yet to that NGS. So what are the scenario or what are the patient perspective that you consider for doing this NGS? Only for the young ones, or you have something to Dr. Mehak only? Yes.
Yeah, usually for the young ones. Some like this 29-year-old, I would if he has the fund, I would offer that.
Okay. Thank
okay.
you.
Okay. So
And
this
We
NGS.
also do fish alone, but I just have a little different thoughts about the imaging modality because I think MRI MSK is also, I mean, it's comparable to PET or some, I mean, in some studies it is actually preferred over PET scan. So our first choice is usually MRI whole body MSK, and that is a little bit cheaper than PET as well. That
one
would be
thing.
our first imaging.
So I would like to add one more thing. For our my training time, it was more about whole body low-dose CT because patients at AIMS were not that affording, and the time period for waiting for PET was like more. But here, where I am in a corporate setup, we do more CXCR for PET rather than FDG PET. So because the sensitivity, specificity, and for the monitoring purposes, it is better. Though it's
Follow-ups.
not recommended by MWG, maybe it will come up in future. But we have seen FDG, PET, and CXCR4 discordance on follow-up, and the responses are better when it is CXCR4 PET negative rather than FDG PET negative.
So is it like for the follow-up, when are you going to repeat the PET scan when you were considering the CXCR4 PET?
So mostly it is after the transplant day 100. If we are going ahead with transplant, if it is transplant ineligible, we usually do before starting the maintenance.
Okay.
Yeah.
Right. So let's see what the guidelines do say. So imaging in myeloma, the International Myeloma Working Group guidelines say yes, low dose whole body CT recommended over scheduled survey for the disease of myeloma bone disease. Whole body MRI is recommended in certain situations. Those situations would be if a low dose CT or a PET would be negative and there were no other myeloma defining events, then definitely do a whole body MRI. If not a whole body MRI, MRI of the spine and pelvis is also okay. PET CT can be used instead of low dose whole body CT, but the CT part of PET CT should fulfill the criteria of the diagnostic whole body CT. And of course, if during follow up, if there is any symptoms, then focused imaging of the symptomatic areas during the course of anti-myeloma therapy is recommended. So this is regarding FDG PET and whole body MRI. So FDG PET, its advantage are two. It is gold standard in detection of EMD, as how Dr. Nakul has told us, not the MRI, and it has a role in response assessment. It is again gold standard. The whole body MRI, although recommended by the British guidelines, I'm not so sure we followed up, and everyone follows it up in a response assessment. But the whole body MRI is better for diffuse BM involvement, for paraspinal lesions, and for focal lesions. That this is wrong. Local sensitivity is wrong. That's a mistake. So this is an algorithm which I noticed. So if you have a myeloma, low dose CT or an FDG PET, if it is positive, treat as myeloma. If negative, and if there are no myeloma defining events, go for a whole body MRI. If negative, then we can safely diagnose it as SMM, smoldering myeloma. CXCR4 PET, yes, agree. I agree. There is data regarding CXCR4 rather than FDG, but I would still require some mature data for the same, Dr. Mehak. I think we are very comfortable with FDG PET.
It is more of an institutional protocol. We'll probably come up with our data, but yeah.
Agree. If your data changes the standard of care, it will be beautiful. I agree. Totally. Coming up to cytogenetic abnormalities in myeloma, we have the IGS translocations, the common one being 11, 14, 6, 14, 12, 14, 4, 14, 14, 16, 4, 14, and 8, 14. Second most common are hyperdiploidy, defined as gains in 3 or more odd number chromosomes, deletions or mutations in TP53, gains of chromosome 1q and loss of 1p, monosomies or partial deletions of chromosome 13, MYC rearrangements, and mutually exclusive mutations in KRAS, NRAS, and BRAF may be seen in 40% of myeloma. So what do we do? So we do everyone does a FISH, right? But then a FISH has to cover all these at least minimum. We should do a FISH for TP50 deletion, 1p amplification, 1q deletion. After that, we have to do a break apart probe for IGH rearrangement. If they are positive, then you go for testing 414, 14, 16, 14, 20, 11, 14. But then this will not really cover your TP53 mutations. You would require an NGS for the same. So these are the recommended FISH panels by various experts. In newly diagnosed NCCN says you do an IGH reflex panel for 414, 14, 16, 14, 20, 11, 14, a TP50 deletion or mutation, 1p deletion, 1q gain, 13q monosomy, and MYC rearrangement. So the third question was, how do you define an high risk myeloma? Could anyone, let's say Dr. Mopali, if you would like to answer this question. Okay, then let's just go to Dr. Nutan.
Yeah, so
Yes.
any of the high risk features in the fish, what we usually our fish involves the high risk panel. So if there is I mean 17p deletion TP53, or if there is any other high risk translocations including 1416 or 1420 or even 414 for that matter. So all these are considered as a high risk myeloma.
Myeloma.
And if the LDH is high, so and there is a RIS is scoring,
Yes.
right? So if it is, yeah, so depending on that as well, the one who have a high LDH, so those are considered as high risk mellomas.
Right,
So,
right.
also I'd like to add a couple of things. Like we were already discussing about the extramedullary disease. If we
Correct.
if we
Yeah.
have some clinical suspicion, we also like to consider this to be also considered in the high risk disease or high risk myelomas.
Yes, I
Also the plasma
totally
cell
agree.
leukemias as well.
Leukemia,
Yes,
in part,
yes,
yes.
yes,
Those, yes, yeah.
And
yes.
I
All
think it
these,
is also about functional high risk, the disease
yes,
kinetics, how we go about it. And if we are seeing an early transplant, let's say 12 months, and within the transplant, the patient relapses, or 18 months, or a primary refractory kind of disease, that also I think classifies as a functional high risk and a high risk myeloma.
yes, yes. Perfect, perfect. So all of these, they don't really do well with your usual chemotherapies, and they could be called as high risk. Now let us see. It's not very easy to define a high risk myeloma with one definition. So this article published in 2024, it defined ultra high risk myeloma as myeloma leading to death within 24 to 36 months of diagnosis, and a high risk myeloma as a myeloma leading to death within 36 to 60 months. They did not really say regarding what exactly does it define. So let's just, so as Dr. Newton said, there are a lot of risk stratification models currently in multiple myeloma which define high risk depending on what all they carry. RIS is one which uses beta 2 microglobin, albumin, LDH, or the high risk genetic features to categorize myeloma patients into high risk. But we all know that is not really enough. Currently, in so this IMS and International Myeloma Working Group consensus came out with the genomic staging of high-risk multiple myeloma. Their criteria for high-risk multiple myeloma was deletion 15p and or TP53 mutation. This was assessed by an NGS-based method. So maybe in the future, FISH might not be enough. We'll have to do an NGS baseline for almost everyone. One of the translocations, T14, 414, 1416, or 420, co-occurring with 1Q amp or deletion 1p. Monoallelic deletion 1p32 along with 1Q amp or biallelic deletion 1p32. High beta microglobulin with a normal creat. So this consensus defined a high-risk myeloma by this criteria, and not the least, but there is something called as functional high-risk myeloma, in which there are a certain number of low-risk myeloma patients who are either refractory or relapsed. They just do not respond. So they relapse within 12 to 18 months after their first treatment. In this individuals, there is some high-risk biology which results from treatment-induced selection of a highly resistant clone or inadequate baseline assessment. We do not know, but they seem to behave badly. So these are the ones who are functionally high risk myeloma. They do not have your proper high risk definition, but they are bad. They respond badly. And there are so many scores right now to define what is functional high risk myeloma. The EBMT, the CIB-MTR, a lot of scores which will define functional high risk myeloma. So I think all together, I think we can agree on this. High risk multiple myeloma, we could define as a biallelic TP53 inactivation more or equal to 2 high risk cytogenetic deletion 15 17p, TP53 mutation 1q gain, 1q amp, deletion 1p, 414, 1416, 1420, 2 or more than 2, and EMD, a plasma cell leukemia, and a functional high risk. All these would constitute as high risk myeloma. So this patient of us, now remember, he was diagnosed 20 years back. So we gave him VAD for 6 cycles. We did counsel him regarding auto. SPB, he responded, but he was not willing for auto. He responded. He was on thalidomide maintenance till 2008, around 8 years. He had some complications of DVT, proteus vulgaris, UTI, hypocalcemia, but everything resolved. So my questions to the panelists are now, so this is not 20 years back. We don't give VAD right now upfront for a multiple myeloma. So how would you choose the upfront therapy in a multiple myeloma who's transplant eligible, transplant ineligible, elderly or frail, and a transplant eligible myeloma with an AKI? Anyone can take this question.
I think
So,
Yeah, so I'll
Yes, yes, yes.
yeah,
who is speaking.
Go
Yeah,
ahead,
you can
go
continue, no
ahead.
problem.
Yeah, so I think it is more about the finances of the patient, regardless of whatever out of the four categories the patient is in. If affording, yes, a CD38 based induction, transplant eligible versus ineligible, the number of cycles vary. 4 cycles take up for transplant. If ineligible, 9 to 12 cycles. For elderly, frail, we have the MIA trial, and if affording DRD, I would prefer. If very frail, maybe RD, or sometimes it is just R for extremely frail old patients. And for transplant in eligible patients with AKI, I would go for LEN unless until the CRET is less than 30, where I will go for a VCT based regimen with DARA. And again, once the renal function comes better, I would take up the patient for transplant. In fact, even if the patient is on dialysis, I did have this conversation with Dr. Shaji. They told that take up the patient for transplant, though we are a bit hesitant at our center to take a patient on dialysis for transplant, but that was his perception,
Mhm.
right?
Right. Yes. Anyone else has any views regarding this? Upfront
So
therapy
just
in a myeloma. Yes.
yeah, so I agree for the other part, as in the standard risk myeloma transplant ineligible, so VRD and this. Just a few changes that we practice here is one thing is for the patient who has a deranged creat, wherein the it is not possible to give lenalidomide because of the creat clearance is low. So, or even if it's actually if the creat is somewhere around 2 3, so there we usually prefer pomalidomide upfront, like VPD, that's the regimen that we
Repeat.
prefer. And there is some data to say that VPD is little better for uh, patients with a renal dysfunction. So that's what we start with. And other thing is, we have done transplants on the patients who have been on dialysis. It is just few changes we have to do is we have to the melphalan that is given as 140, that we have to split it and give it in 2 days, 70 mg per meter per square. It's divided and given on 2 subsequent days. So yeah. So
I
it's
just
still
want
feasible, but if the patient is, I mean, if the creat is very high, if it's elderly patient, so then it again, it's basically a discussion with the patient about, the outcomes, and it's just going to increase the PFS, not the overall survival. So how much they really uh, are willing for the transplant, because definitely what we explain for the autologous mortality is definitely a little bit more for the patients who have a renal dysfunction. So, yeah.
So, ma'am, any of your patients who were previously on dialysis post transplant, have they come out of dialysis?
Yeah, not post transplants. I mean, whatever I could remember, there are patients who required dialysis initially, maybe for 1 or 2 cycles. Maybe after 2 3 cycles, the creat has improved, and by the time transplant is happening after 4 cycles, they are not no more on dialysis, and then we have taken up for transplant.
So,
But I don't
otherwise,
remember any patient who was, after 4 cycles was also on dialysis, and I don't think beyond that point the renal function recoveries.
Yes.
Uh, I don't think it's possible.
So I think what Dr. Mehak wants to ask is, was the patient dialysis dependent and taken for transplant, right?
yeah, that was the question.
Yes.
Yes.
And the other one was whether they became dialysis independent after the
Post
transplant.
transplant. Yes.
No, so we have taken patients with who are dialysis dependent for transplant, but they have not become dialysis independent after that. It is just done to,
For PFS.
it's myeloma. It's going to, yeah, it's the whatever the damaged kidneys have undergone, that will not recover. But whatever the clone is there in the marrow, who is going to come back again. So it's just for that PFS benefit.
Right.
So I don't remember any patient who was dependent and then has become not like independent. That I
Ah,
don't remember any
yes.
such patient.
Yes.
But
Yes.
of
So
course, it's like very less number of patients.
yes. 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 So once they do become transplant dependent after 2 to 4 cycles, I don't think they do come out of it. It is something
Yeah.
which is chronic and it is going to be there no matter what you do. Even
Yes.
transplant might not really improve it. But
Yes.
yes, there's one more, because even I haven't done a transplant with whose patient who's dialysis dependent. Did you see? I just wanted to know whether more chances of infection and cytopenias, was it delayed recovery? So I remember some data saying that you can do a transplant even when they're ISD dependent, but the recovery is too late, and that exposes to the patients to a lot of cytopenias and neutropenia, increasing the rate of infection. I just wanted to know if you did have the same
So,
experience.
so the complications are definitely more if you are a dialysis dependent. Then, but I don't remember that the recovery was late. But the complications are more in terms of including the metabolic complications, because this mucositis and the bicarb will go, they will require acid. I mean, they will go in acidosis. So all those sort of complications, including probably infections, were also more. What I remember is like one patient had a very bad viral infection. So these complications are more, but I don't see that the cytopenia recovery was late. So,
Okay. Okay. Okay.
and of
Thank you.
course, it's a more mortality than the usual, like a
Right.
normal create patient. So that has to
Yes.
be a discussion with the patient.
Yes. Yes. Right.
And now, currently, because we have a lot of other options also for maintenance, so like direct movement, so it has to be a discussion with the patient that like what they really want.
Mm. Right. Perfect answers from everyone. So these are all the latest trials from newly diagnosed multiple myeloma who are transplant eligible. The Griffin did show that Griffin, which we use for DARA VRD with transplant, again with DARA VRD consolidation, DARA-LEN maintenance, established some proof of concept that the quadruplet improves the depth of response. Similar with Cassiopeia, DARA VTD with transplant, again DARA VTD consolidation and DARA maintenance. This was one of the first phase 3 trials showing benefit of quads. Perseus is with subcute DARA. This is the benchmark right now. If there are no cost issues, subcute DARA VRD with transplant would be the best. Ischia again showed ISA-KRD also, one of the trials which has highest MRD negativity, and of course the master, which now shows that treatment can be stopped if MRD is negative. So beautiful results with quadruplets in a newly diagnosed transplant eligible multiple myeloma. That would be the standard of care this time. What about transplant ineligible? Again, the SWOG data showed initially that VRD is better than RD, substantially deepens the response as compared to RD. Then there were the trials with DARA, Maya, DRD versus RD, established continuous DRD as benchmark frontline. The Cepheus and Alcyon, they they established that a quadruplet again would be better, and a quadruplet with DARA VRD also is the standard without ASCT. IMROS also confirmed that ISA VRD could be one of the options, not only DARA. So the benefit of quadruplets is not limited to DARA. But all these are clinical trials. They are very good. The environment is controlled. They are done very nicely in a controlled environment. Everything is okay. But we need some real world data and real world evidence to match this. So this is one of the articles which showed real world evidence of DARA in newly diagnosed multiple myeloma. This was a multi-center retrospective cohort study from southern China. So they had, what practical problems we do face in DARA is you cannot really give it for a longer time because of financial constraints in India. In the US, it is covered in all the policies in the insurances, but out of US, a lot of insurances do not cover it. So giving DARA at 16 mg per meter square, like how they are in trials, is going to be difficult. So in this real world evidence of daratumumab in newly diagnosed multiple myeloma from southern China, there were a group of patients. There were 177 patients who got daratumumab based therapy, and 584 who got your other DARA, not DARA based therapy. The decision of auto was according to both patient preference and physician discretion, and maintenance was administered to all. So now look at this PFS and the OS data. The PFS at 3 years is around 75% with DVRD, which was the commonest regimen, and it goes to around 40 with the others without DARA. Similarly, with OS, a 3-year OS benefit was clearly seen with DARA-based regimens, and it almost plateaued. This is one of the real-world data in daratumumab. And again, similarly, the ORR was around 96% with DARA-based therapy, 87 with the other based therapy. Rates of VGPR were higher, 86% with DARA-based therapy, 57 with the control. And even the MRD negativity rates were 79% with DARA-based and 50 with your other therapies. This is again a table of the same, showing 3-year PFS, 3-year OS, more than VGPR and MRD negativity. All of them were better with daratumumab-based therapies. Also, the benefit from daratumumab-based therapies with regard to both PFS and OS was consistent across most subgroups. However, in this real-world data, daratumumab-based therapy had no benefit in PFS and OS among subjects with deletion 17p and 414. Daratumumab-based therapies only conferred a trend of OS benefit 1 q amp or gain, and they did not show any significant improvement with more than two high-risk cytogenetic abnormalities. So the conclusion is yes, daratumumab based quads are the standard of therapy, but it might be difficult for everyone to give it. There might be some increase in the decrease in the increase in the frequency or decrease in the dose, trying to give some amount of daratumumab. That is why a real world evidence is needed, and the real world evidence does prove that daratumumab improves PFS OS, which were consistent with the report of all the clinical trials which we mentioned before. Although subjects received limited doses of daratumumab-based therapy in this Chinese real-world data, benefits were still seen, indicating that the importance of disease control and response depth in initial treatment is very important. So coming to AKI, yes, we usually do DARA VCD, but even in AKI, in patients with AKI, you can still give LEN depending on the creat clearance. In less than 15 also, you can give 5 mg per day, can be increased to 15 mg per day if there's no toxicity of lenalidomide. If it is more than 60, the creat clearance is more than 60 ml per minute, you can give 25 mg per day len. That is the max dose. So this again would be an algorithm of how would you treat it. Transplant eligible, ineligible, DARA VRD is the treatment of choice. For transplant eligible, consolidated with ASCT, standard risk, LEN or LEN with DARA, but for high risk, definitely a doublet maintenance, LEN with BOTE or LEN with DARA maintenance. And then also continues. So this patient again, now in 2016, he presented with severe body ache along with pain in the right shoulder and upper back. He had some anemia, creat was 2.7, calcium was 11. Again, showed a lot of plasma cells. Fish showed trisomy of chromosomes 5, 9, and 15 with a monosomy of 30q. So now my question to the panelists are, how do you monitor a patient of myeloma? What is your treatment strategy for maintenance? And how would you go for treating the first relapse of myeloma? Again, this is right now, not 20 years back. Could we have Dr. Devyani answer this?
Yes. So monitoring is based on myeloma profile, which we do every 3 months. But yes, if a patient is on quadriplex, we do it after initial 4 doses of DARA, and then ideally should be after 2 cycles, that is 8 doses of weekly DARA. Thereafter, one before T transplant, and then monitoring every 3 monthly with bone marrow as well as myeloma profile done at day 100, followed by 3 monthly then.
Yes.
Treatment strategy, yes. For maintenance, if it is a standard risk, I would go for a single agent. And if it is high risk, then we use double maintenance, len, dara, or body len.
A first relapse in this scenario in 2026?
Post relapse, it actually depends on time of relapse. How much time has it passed? Like if it is very early, functionally high risk, then yes. If not previously exposed, we would go for CD38. If not previously exposed, then otherwise, now Dara, Teclista, CAR-T, they are coming up. So, but if it is a late relapse, more than 5 years, then we can retreat it. If the relapse is between 1 to 3 years, we can use based on whether it is lens sensitive or lens refractory, and then use carfilzomib based therapies.
Right. Does anyone else have anything to add or contribute to this?
For
Just
the
one thing to add.
Ma'am, you go ahead.
Okay, sorry. Yeah. Just one thing to add. So this monitoring of myeloma parameters, when we look, to monitor it, like when we are monitoring protein electrophoresis, the baseline M band should be at least 1. if you want to monitor the as in M band. Otherwise, if it's less than 1 to begin with, we should be monitoring the free like a lambda ratio that should be monitored ahead as we go, because sometimes it may not be like the heavy chain, it's just a light chains which are there. So,
Right.
so that's just one thing to add.
Right.
Yes,
For
Uttamai.
that first relapse post, how do we go about it? It is more about the finances and what the patient has been exposed to. For a patient who has had a good response with DARA initially, and it has been, let's say, an year or so after the patient has relapsed, we can also re-expose to the same anti-CD38 one. Second, no finances, probably go for a KPD kind of a regimen. If yes, finances, CD38 exposed, then probably for bispecific CAR-T we do not have in our country.
Mhm.
And for certain translocation, let's say 11, 14, we can also challenge the patient with venetoclax based regimen.
Right, right. So I just had a question. Monitoring, you all do your myeloma panels every cycle or every 2 cycles?
We do every cycle, every 4 doses we do it. It is more for a
Mhm.
psychological thing as the disease is
Yeah.
progressing. Even though the right ways, yes, we can continue up to 8 doses before we tell yes, it is primary refractory kind of disease. But we do it
We
every
do it
month.
every 2 months. We do it every
You
two
know,
months
yes, we
initially
also do
until
every 2 months
transplant.
initially. If we are
Yeah.
considering an
And
early
after transplant,
transplant.
every 3 months.
Yeah,
Yeah.
same.
Mhm. So no, so during your induction, you usually people do follow after 2 cycles of every therapy to do an SFLC or an SPEP. But yeah, the guidelines would say every cycle, after every cycle, you have to do it. So yes, so monitoring again, this we discussed. Maintenance, again, defined as any therapy given after completion of induction for a prolonged period of time with the goal of extending the duration of response, prolonging PFS and OS, while maintaining a good quality of life. Ideally, should have an acceptable toxicity profile and should not compromise treatment relapse. Lot of trials with maintenance. One of the best is going to be the Auriga, which showed that if you add Dara-Len to a patient who is anti-CD30 antibody naive, you have an MRD positive. Estimated 30-month PFS was 82.7 for Dara-Len and only 66.4 with Len. Rest Griffin Persis also said the same. So these are trials in which there was maintenance given without transplant. Not a lot of data in that. Only 3 trials which showed the first trial in which MPT was the induction. I don't think so. We give it right now as the induction with RD maintenance. PFS was better with RD. Tourmaline MM4, PI or IMID induction with isaximib maintenance. PFS was better with isaximib with only 9.4 with placebo. And the MM015 trial in which MPR was given was MPR or MP with LEN maintenance. PFS was better with LEN. Again, as everyone knows, standard risk LEN or Len with Dara, but with high risk, definitely you give a doublet maintenance with Len plus PI or Len with Dara. So relapse, again, everyone was used right, but a shared decision regarding patient's tolerance, prior treatments, the cytogenetic risk, comorbidities, and frailty. Possibly, if it has been an early relapse, offer regimens that include agents different than those of received prior. Preferred options relapse would be teclistamab dara, cilta-cel. Other options would be ide-cel or any triplet therapy, including belantamab. For eligible patients, bispecific. For patients who cannot be given bispecifics, triplets or CAR-T, you would be okay with the doublet. So now, currently, the data with teclistamab dara is very new and very important. So Majestic 3. So this was a randomized phase 3 multicenter trial comparing Tec Dara to DPD or DVD. In this, the patients, 1 or 3 lines of patients therapies, including PI and IMID, anti-CD30 for antibody refractoriness was not allowed, and previous anti-BCMA antibodies were excluded, and the primary objective was PFS. So these are the demographics and baseline characteristics of both Tec Dara and DPD DRD. Both were almost well balanced. You see that the PFS, 36-month PFS was 83.4 with Tec Dara and only 29.7 in DPD or DVD arm with a p-value of less than 0.001. Similarly, 36-month overall survival was 83% with Tec Dara and 65 with DPD DVD with a p-value of less than 0.01. So estimated 36-month PFS 83 versus 29. Estimated 36-month OS 83 versus 65. CR or better with tech data 81%, while only 32% with DPD and DVD. MRD negativity again higher with tech data. Medium time until first response almost the same, but the duration of response not eligible for tech data, but it was 23.5 months for DPD or DVD. The PFS benefit favored tech data across almost all clinically relevant subgroups, plasmacytomas as well as high-risk cytogenic abnormalities. Safety-wise, yes, grade 3, grade 4 neutropenias were almost the same. SAEs were more with tech data. Deaths, grade 3, grade 4 infections were more with tech data. Fatal infections were more with tech data. Hypogammaglobulinemia was more. But the CRS which occurred with tech data was 60%, but most of them were grade 1, grade 2, most of them very transient and with a median duration of only 2 days. ICANS occurred in 3 patients with tech data, one being grade 4, leading to discontinuation of teclistamab. So the conclusion with this Majestic 3 was, yes, it shows unprecedented efficacy. It supports the combination of bispecifics and anti-CD38 antibody in the second line of therapy. It could be a potential for functional cure, likely due to synergy of both the bispecifics and anti-CD38. Good news for the CRS and ICANS rates were lower than the observed ones in Majestic 1, teclistamab monotherapy. Neutropenia and infection rate were higher, but could be managed with IVIG prophylaxis and antimicrobial prophylaxis. The only issue was that only 5% were DARA exposed. Therefore, it would really need a real world evidence and data to confirm these findings. As at present, if there's no affordable issue, we do give DARA in first line or second line. And tech DARA would require indefinite treatment and it might burn the bridge for the CAR. So now this patient, he was given Cybody for 2 cycles. Then because his CRAT was high, came down, we gave VRD, again not willing for auto. He was on bortezomib maintenance after achieving VGPR, tolerated well. Again relapse, no complaints, but SFLC ratio was increasing. PET showed a PET A-bit soft tissue mass. CBC CRAT was okay. We giving KPD for 7 cycles, again not willing for auto. Just reminding you, this patient was 29 when he got diagnosed. So after again KPD, he did respond, again had a VGPR, put on POM maintenance, again tolerated well. He just had some neuropathies and some grade 2, grade 3 cytopenias which were managed well. Third relapse again in 2022. We gave him DARA VDD 8 cycles, again had a VGPR, put him on DARA maintenance till 2024 with some dose reduction due to financial constraints, even once in a month or once in 2 months, sometimes decreasing the dose because finances were an issue. Again planned for ACT, but here he had apheresis failure. Complications again, he had an E. coli induced UTI, dengue induced ARDS, relapsed again. This in 2024. No complaints. SFLC was rising. PET showed a metabolically active lesion in the left iliac bone. CBC wise, creat wise, calcium was normal. Now, this patient has relapsed 4 times, has been exposed to anti-CD38s, PIs, IMIDs. So now, this is again a question to almost everyone. How would you approach a triple class exposed multiple myeloma, considering that they do not have great overall survival? Anyone could do this. Yes. Yes.
So yeah, TC triple class refractory exposed myeloma. The next line is a bispecific. We don't have cilta-cel or ED-cell with us, so some of our patients have gone and got it done. But yeah, teclistamab, elrantamab has recently been launched. So for now, I believe the finances were okay because he took data for a long time. So for him, I think teclistamab will be the next option. Even though he has those comorbidities and ECOG PS most will be around 2 or so, considering what I'm seeing from this thing. But still, we have I think 15, 16 patients outside the trial whom we have given teclistamab with varying PS, and they have done extremely well. So I would not hesitate in offering the patient bispecific.
Right. Anyone else?
So I'd like to comment on I have come across a similar patient of mine who is having a similar profile. In spite of that, the patient was definitely not diagnosed this young, but he is also currently triple class refractory. Was
Yes.
on Dara maintenance, had a like plasmacytoma. We had advised the patient for radiation even at times when there was some extramedullary relapse. And now we are considering whether to give a bispecific in the term of teclistamab or elranatamab. If we consider the studies that we have, might be at present what Dr. Mehak also told about, we will be going with the teclistamab. And elranatamab, I think, will take some time to have some data for real world data in our hands in our segment.
Right, right.
For
Perfect.
ma'am, AMD, we have 3 patients whom we are giving this combination of tactile, according to redirect and AMD. Two of them have done extremely well. No doubt with that, Tilkitamab importing that 40 mg vial cost around 7 lakh rupees.
Yes.
We do a bit of vial sharing as well, but yeah, that's how it is.
Correct. That
Yeah,
is really
finances are basically a constraint for myeloma patients who are having this long run of treatments and are currently on a triple class refractory with having data for a long time. So really, that is a financial constraint is a problem.
yes.
So this when you're starting teclistamab for such patients, you are continuing it indefinitely until relapse.
Yes, ma'am. So the data, the Majestic 3 says that CR for more than 6 months, and then when you reduce it to two weekly, we don't have that much finances, and patient cannot do it for indefinitely, even though there are this concept of drug holiday and TFR with teclistamab. So what we do, we try to give at least 8 doses once per week. Then we shift on to once every 2 weeks. But again, that comes with that cost of how many infections the patient is having, what is the cost, and how the disease is responding to teclistamab. No hard and fast rule, not following the exact guidelines because it is more about finances. So try to give 8 doses weekly. But then
Because for
IVIG
such patient,
monthly, sorry,
yeah,
right.
tell me.
So we do give IVIG monthly. That is the norm, regardless of the immunoglobulin levels. We try to maintain IgG around 800, and prophylactic TOSI at the beginning. That is also a norm.
Because for just one thought for such a young patient with extramedullary disease, with a bad disease biology, with multiple relapses, sometimes for us it is difficult to maintain that that teclistamab for long time. So there is it's not a standardized thing, but I think in countries like India there is a role for allo transplant also for such patients who have multiple relapses and a lot of extramedullary disease, bad biology, young patient. So that's also one thought for this patient.
And tandem also, I believe, especially for TP53 cases. So
Yeah.
these two cases, I do agree, especially in a country where the financial toxicity is the main concern, allogenic
Yeah.
TMT
Yeah.
still has a role.
Right.
Yeah, because this patient has failed mobilization also. So auto is not possible for him. So
Right.
Right, right. Yeah, all great options. So here, I just wanted your opinion because data was too much in this for me to put in this moment. We did give him teclistamab, but he did not respond at all. In fact, his SFLC kept on increasing. He also had an LRTI with pancytopenia with AKI during this. And then again, we switched him to VMP, on which he had initially responded, but left again with AMD after 6 cycles. He was counseled for talquetamab, CAR-T, but due to logistic issues, both could not be given. We took few consults. We thought we'll give him since he has an AMD, we would give him some alkylator-based therapy and then plan for an allo once this is consolidated, but he could not really tolerate that. He expired on day 22 of VDD pace with an LRTI. And so that was the case discussion. Just an update from myeloma. Majestic 9 again has teclistamab in Len and anti-CD38 antibody exposed myeloma. Successor 2 has mezigdomide KD versus KD. And Tentamic, again a CD3 CD BCMA bispecific in prior BCMA exposed myeloma. KLN 1010 and in vivo CAR-T induced MRD negativity response in 6 patients. Elrantamab in smoldering myeloma. It showed that it delays the progression 95% at 9 months. Again, still we need to read regarding this. Still we need to learn the data. Okay, so that was the case discussion. I thank all the participants, Dr. Devyani, Dr. Mehak, Dr. Nutan, and Dr. Mopali for taking part in this. This was a lovely discussion. I hope Dr. Nakul and Dr. Jyoti are still there. Thank you both, Dr. Nakul, Dr. Jyoti, both. So this is important. So, USA-based trials are something which are standard of care, but we are not sure how we do practice them in your real world. We in KM are very resource constrained. We are not be able to give DARA to a lot of people. Say maybe 10-20% people do afford DARA. Again, people who have ESIC, who have BEST, who have some kind of insurance, we do give it. We do consolidate any patient who is transplant eligible with ACT. Yes, bispecifics, again, we have not given it to a lot of people. 4-5 of teclistamab, that is it. We try to import talquetamab. So this patient is really close to me. All these 20 years, he has been there in KEM. He did it for 20 years. I think that is also very amazing. And he did make it to this era in which we had teclistamab, talquetamab. Unfortunately, with the finances, we could not do it. Insurance, everything was exhausted. His wife also thought of getting talquetamab, but they could only do it for only one cycle. We did not know if that would respond or no. We did counsel them. Then she said, and getting talquetamab, importing it takes around 8 weeks, is what we found out regarding the logistics. So we could not really keep him like that. Yes, Dr. Mehak, you want to say something regarding talquetamab importing?
It's we have outside trial. We have 7-8 patients on tilkitamab. Most of plasma cell leukemia and EMDs doing well. So the time period of 8 weeks has reduced a bit. It can be imported early. We get it in a week, 2 weeks time.
That is great. I should send such
Yeah,
patients to you, Dr.
share
Mehak.
number. Right. Yeah.
Yes, yes. But then we were told it was 8 weeks. The logistics and the payment would take 8 weeks. And definitely we cannot keep him like this with 8 weeks. We counseled the wife. He's young, he has 2 kids. He was just 49. That's almost when people are not even diagnosed.
Right.
So we sat down with the wife. We told them, yes, talquetamab is an option, but we need to consolidate. It's not going to remain, and we cannot give talquetamab forever. We don't have so much finances. Or we give him an alkylator-based therapy since AMD works decent and consolidate with allo. That was our plan. Sadly, he did not make it, but he did teach us a lot of things from all his management. We learned a lot, and I think that is how we learn. All the real world data and real world experience is much more different than what is in the trials in the US. So thank you, Dr. Mehak, thank you, Dr. Nutan. It was lovely, Dr. Mopali and Dr.
Thanks a lot.
Devyani.
Good,
Thank you
nice
Thank
so much.
you.
discussion.
This was
Thanks a
Beautifully
lot.
Lovely
managed.
interacting with you all.
I would also thank
Nice
IAO
discussion. Yeah.
for this. Yes, Dr. Mopali.
Yeah, thanks a lot. It was an enriching session to all of you.
Yes, yes. I agree. That's why we should have these sessions. All the young hematologists who will become the top hematologists and who will decide the standard of care in the next 10 to 20 years. We should have this more to think what we are doing right now. Right. So thank you everyone. Thank you IAO to give us this opportunity and discussing this. Have a lovely day. Thank you.
Thank you, Dr. Chair.
Bye.
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 Thanks a lot.
Bye.
Sir, can I conclude?
Yes, sure. Please, come.
As we wrap up this enlightening evening, I would like to express our deepest gratitude to Dr. Jay Jovikar for his leadership as Program Director, our faculty speakers, and every single attendee who took the time to join us today. All the participants will be receiving their certificate within 2 to 3 working days to your registered mail ID. I repeat, all the participants will be receiving their certificate within 2 to 3 working days to your registered mail ID. We look forward to your participation in future IAIO academic initiatives. On behalf of IAIO, thank you once again. Have a great evening ahead. Thank you.
Thank you.
Thank you, sir.